All right. Well, thank you again for sticking with us. It's been an amazing event so far. I've learned a lot. So I want to introduce to you Dr. Amber Johnson. Dr. Johnson is an assistant professor of medicine and clinical and translational science at the University of Pittsburgh. She is also a staff cardiologist at the Veterans Administration Public Pittsburgh Health System and a faculty affiliate at the Center for Race and Social Problems at the University of Pittsburgh School of Social Work. Dr. Johnson's research is at the interface of health and mobile health technology. Her research has resulted in numerous publications and federal grant funding. Dr. Johnson also serves on the Black Equity Coalition, Health Equity Working Group, and is committed to addressing racial inequality in cardiovascular care. She is also the mother of two beautiful and smart young girls, Lilani and Nia, and I think they are our youngest audience members, future doctors, future inventors, and future venture capitalists, perhaps. So with that, thank you.
Thank you.
Okay, so Dr. Johnson, what's one statistic or fact about healthcare disparity in Pittsburgh that you think we would find shocking?
Well, I don't know if you'll find this shocking now because the data have circulated for the past few years, but it still kind of sends shivers up my spine when I realize that the death rate for Black women giving birth is twice that of white women in Pittsburgh. And when you compare the rates or the disparities in Pittsburgh with other similar cities across the nation, that Pittsburgh fares far worse. So I think that those data are shocking. The report that was done that came out, I want to say like 4 or 5 years ago now, got a lot of news, it got a lot of press, and a lot of institutions, including the University of Pittsburgh, have been exploring the mechanisms as to why that is.
So healthcare disparity in the Pittsburgh Black community is prevalent and well documented. What are some of the major contributors to this disparity?
Well, I think there's a lot of contributors. I referenced the Pittsburgh study that showed the disparities for Black versus white maternal mortality. That study was very thorough in that it looked at a lot of social determinants that contribute to health outcomes. And so when you look at things like upward mobility, the ability for people to gain wealth throughout their generation or intergenerational, that is different for white versus Black and other race and ethnic groups. When you look at the ability to do well in school, even at the grade school level, you can see differences by race. And so, educational attainment, income, access to care, all of these are social determinants which are related to race. So I don't think it's anything about being Black specifically, but I think that there are these disparities when it relates to social determinants of health that then lead to negative outcomes.
Why Pittsburgh? Why do you think that these disparities happen here?
Yeah, I don't know. I had a conversation with a friend of mine. She's an anthropologist, and she teaches a race in I don't think it's race and medicine specifically, but she asked me to come to her class. It's an undergraduate level class at the University of Pittsburgh, and she shared some anecdotes of experiences that she had as a Black woman in Pittsburgh, and she had just moved from New York City to come to Pitt. And she notes the differences, the discrepancies in New York City compared with in Pittsburgh. And she asked me that same question, like, why is this the case? And I don't know. I mean, there's a lot of structural barriers that are persistent here. I think just because of the geography of Pittsburgh, the topography of Pittsburgh, people kind of get into these silos. And I mean, I'm seeing some people nodding their heads like, if you live in Squirrel Hill, for example, like when's the last time you went to the north side? Like people don't cross bridges, people don't go through tunnels. And so you kind of know what you know about your neighborhood and your little silo, and you don't really get to learn about other people, other cultures. And I'm not saying that as a blanket statement, but I think that those types of culture, the sort of structural barriers that are in place, do play a role. So I think that that's probably a factor, but I really can't pinpoint why it is that these disparities are worse in Pittsburgh compared with other similar cities.
Yeah, it's fascinating. I'm not from Pittsburgh originally. I'm from Baltimore, and came here for grad school. And I think that was one of the things that was the most shocking to me was the silos that people sort of created. But it was interesting because they are generational. And I find that these silos have been inherited almost, where I've heard of friends who recall their grandparents telling them not to go to certain places in Pittsburgh because of what they experienced when they were children and teenagers and young adults. But here you are, many, many years later, generations later, and there's still this fear, resistance almost to it. And it is interesting to think about how that impacts access to healthcare. And when you think about the sort of the topography of Pittsburgh and the health care that we have basically two major systems in here, excluding the Veterans Health Administration. So the general population really has about two places to go. But what happens when your primary care physician, who has all of your records, all of your information, decides to move or switches systems? What do you sort of see within the Black community in terms of really wanting to stick to their tried and true and not being willing to go to see a specialist if need be, or go outside of their silo?
Yeah, so that's an interesting question, and I guess I haven't really thought of it that way. I think if I can take a step back, so when we think about disparities in care and when we think about access, what often happens at the hospital level, at the health system level, at the institution level is we think, what is it about certain groups, certain populations that make them not trust us or that make them have difficulty accessing us. And sometimes what can happen is almost like victim blaming, where it's like, oh, they don't trust us. That's their problem. Where it could be flipped on its head. Like maybe we're not doing the things that allow them to trust us, or maybe we've done things that have been actively harmful to these communities. And therefore it makes sense that they wouldn't trust us. Like any person in their right mind wouldn't trust an institution that has harmed us for generations. And so I think that, if I could rephrase the question about like, what is it about our institutions that are not pulling people in? I think the trust issue is huge. The mistrust, distrust is huge. I think that within Pittsburgh, there's been a lot of historical injustices that our institutions have done that have been harmful to our communities. I can think of one example. I don't know why this just came to mind, but I remember a few years ago, CMU was doing a welcome thing for and I think you know what I'm talking about. Like they were doing like some like welcome map or some like online tool for people to who were coming into the institution, coming into undergrad, to know where is a good place to live. And so it was this like interactive map where you can look at, find a place to live in Squirrel Hill or find a place to live in Shady Side or whatever other neighborhoods that were deemed desirable. But there were other neighborhoods that were completely left off the map, like the Hill District and Wilkinsburg. And, maybe if you're looking at an apartment for a freshman, then, maybe that wouldn't be an ideal place for them to live for multiple reasons, but like to completely leave it off the map was like actively harmful towards those communities.
Yeah, absolutely. I think that it's very easy for institutions that operate or are used to operating a certain way to not even pay attention to omission, which I think is oftentimes one of the most difficult things. We know in medical research, even when you're looking at medical students and the diagrams that you all learn from are not people of color. And I think there is a gentleman now who is now redoing those diagrams in those books to show people of color, but it's insane that that's not available now, that it's not always been available.
Yeah, and I think that there are biases that a lot of health professionals, physicians, nurses that we have that become ingrained in us through our training. And if I could go back to the example of the anthropology class, I forget what exactly the subject was, but one of the students was a nursing student. And she said, it's just so shocking to me that this is the only opportunity that I have to learn about race. Whereas in nursing school, the introduction that she had to race was that Black people need to take X medication for blood pressure, whereas white people need to take some other medication for blood pressure. But if you look at those data, it's from studies, probably sub-analyses of larger populations where they found that, the Black participants of a study responded by, 0.2 millimeters of mercury compared with the other group. And so, for generations on, as we're teaching our nursing and medical students, we are teaching them that Black people don't respond to beta blockers, or that, you need to start them on a diuretic first. But just to think about the data upon which, the foundations upon which we are building these racialized conceptions are often faulty. And it's up to us as the teachers of future generations of medical students and nursing students and, other allied professionals, it's up to us to really question what it is that we are teaching as dogma. And then along those lines, I've done a lot of work thinking about the diversification of the workforce and thinking of candidates holistically. And, historically speaking, a lot of medical institutions, residency programs, fellowships, so on, have been thinking about their applicants, about the merit that they have, the board scores, the grades. But oftentimes, those types of educational opportunities, those educational accolades are benefiting white people the most, because we know that there are racial biases in the ways in which people are evaluated. There are racial biases sometimes in the questions on the standardized tests, and then access to educational teaching, better schools, board prep, those sorts of things is very much dependent on socioeconomic status. And so kind of tying back in with the way that we started the conversation about social determinants of health, they tie into health outcomes, but then they also tie into educational access as well.
Absolutely. So if you were to talk to a Black patient and give them advice on how to best advocate for themselves given the circumstances, what are some things that you would offer to them?
Yeah, that's a little bit of a tricky question. There is a study that I was just reading about today where in California, they surveyed Kaiser recipients in the Kaiser Permanente system. And like 3,000 or so Black patients said that they present themselves a certain way when they go to see their doctor. They'll dress up nicely and they'll, be sure that they speak very clearly and enunciate so that they can be taken more seriously. So that when they interact with that healthcare professional, when they interact with the doctor, that the doctor doesn't treat them negatively or, assume that they're drug seeking or any other type of negative stereotypes. So there are these things that patients are doing. What the study didn't show is, does that change outcomes? Does that change the patient-physician interaction? So probably, but maybe not. Who knows? And so, again, like what would I tell a patient? I would say that having an advocate is sometimes helpful. So if you have a brother, sister, spouse, and this kind of goes across the board because, as you mentioned, I see patients at the VA, and a lot of times when the male veteran patients bring their wife with them, their care is just so much different because the wife is like, well, no, honey, that's not what happened. So, like having somebody with you to kind of serve as like collateral information, that's helpful. And that's irrespective of race, gender, whatever. We talked about technology. I feel like a lot of what is being talked about is technology today. And some of my research is looking into digital readiness and understanding how patients from marginalized communities are using technology. With telehealth and wearables and devices and things like that. We know that that's the future of medicine, but there is this digital divide. And so, part of my research will be to understand how it is that Black and marginalized people are better able to benefit from the technology and the advances that are available today.
When you made your first comment about dressing up, my grandmothers, they're both in their 90s, and that was something that they taught me and they taught their children, and you can't catch them at a doctor's appointment completely without being completely dressed to the nines.
Yeah.
So it's just, I think, something that it makes you pause and think, why is that? And
Right.
it's not because they just want to look amazing for their doctors. It's a self-preservation tool. So pretty sobering to think about. So what can all of us in the room, what would you recommend us doing as we know that these disparities are existing? There are some phenomenal startups that are in the room, educators in the room, venture capitalists, executives in large organizations. What can we be doing to help with this disparity?
Yeah, so I think that for the startups and maybe even the venture capitalists who are funding startups, thinking about the development of any type of intervention technology, making sure that it's patient-centered and patient-informed. I think that there's been a boom of digital devices, technology, wearable devices like I was alluding to before. But what I've noticed as a physician and, patient advocate and researcher is that a lot of the technology that's out there is not centered around the patient. It's not usable. It's not user friendly. And so really understanding from a patient's perspective and from a diverse patient's perspective, diversifying the people who are, coming up with AI algorithms. I wrote a paper with some colleagues who are in the heart failure space, and there are these AI algorithms that are coming out that are supposed to improve predictive ability for patients with heart failure, understanding what their outcomes are going to be, treatment strategies and so on. But we know that if the data are biased, then the prediction is not going to be valid. And I think that ties into so many of the other aspects that I'm sure a lot of the folks in the room are working on, is that making sure that the data are valid and reflective of the actual patients that you're hoping to impact.
Those are excellent points. And so my last question Tell us about the Black Equity Coalition. That's how I actually found you.
Yeah.
Was doing a search and heard about your organization. So tell us a little bit about that.
So I've been a member of the Black Equity Coalition for a few years now. I'm on the health equity group. There's some subgroups to it. It started out as Black COVID-19. And so as COVID was getting started and we were seeing such sobering disparities by race, and horrible outcomes across Pittsburgh, a few folks, community advocates, community workers got together to form this grassroots organization. And from there, it's really grown. And so I'm part of the health equity team. There's also a data team. There's a research team. There's like a community building team, like a bunch of different aspects that are covered by the organization. And for the health equity group, we meet regularly, more so when COVID was at its worst. But over the past year or so, we've really been working towards building community presence, understanding community voice, understanding what are the things that are tied with health equity across not just Pittsburgh, but across the state. There's a group in Philly that's been very active, and we've also grown into Harrisburg as well. There's lots of momentum with regard to publicity, marketing, politics, policy. So it really is far reaching. And the ultimate goal is to understand the mechanisms and ensure adequate health outcomes for the people who have been marginalized for so long.
Well, thank you so much for your dedication and your incredible work.
Thank
and we
you.
really appreciate your time.
Thank you.